Well, good morning to my intro psych students. It is 6:30 in the morning. I'm up. I'm drinking my second cup of tea. I'm, as you can see, in a different location. I'm downstairs. What am I doing here? What are you do? What are we doing here? Anyway, I think I kind of remember what we're doing. I'm going to finish up our class today and put out the last lecture on abnormal psychology. And we'll be sending you later today a short exam 3. So let me just mention to you that if you haven't seen the first part of abnormal psych, you really should watch that first so this makes more sense to you. In that first one, I was talking about different ways of defining what the word abnormal means. We talked about psychopathology. We talked about 2 different methods of defining abnormal. The first one is called cultural relativism, and we discussed the pros and cons of that and gave you some examples. And then the second way, which is the method that psychologists in America tend to use, is called the maladaptive model, where we ask the question, is an individual producing behaviors that significantly interfere with either his well-being or with the well-being of other people? We deconstructed that. We talked about what the word well-being means. And so watching that first video on abnormal psych is important to understanding this one. And one of the place that we ended that video, toward the end, we talked about how there are hundreds and hundreds of different psych disorders as discussed in the DSM-5, the book that therapists, mental health professionals use to make a diagnosis. 5 being it's the 5th edition. It's been, the original DSM goes back years and years. And that each of those many different disorders has its own particular set of symptoms, of behaviors that goes with it. I believe that we defined symptoms into 2 main categories. Some symptoms are ego dystonic, dystonic, and those are behaviors. The word dystonic comes from the word dystonia, which means painful or unhappiness. Ego dystonic symptoms are symptoms which are painful to the individual who has those symptoms. So panic, anxiety, for example, are ego dystonic symptoms. They make you suffer. Most of the symptoms of depression are also ego dystonic. Despair and hopelessness, exhaustion are unpleasant. A third example would be if a schizophrenic person is hearing the voice of the devil, they're having an auditory hallucination and they're hearing the devil talking to them and saying very, very distressing things. Those are ego dystonic symptoms. Flip side of that, there are symptoms seen in many different psych disorders that are ego syntonic, syntonic. And these are still symptoms because they interfere with well-being. But by syntonic, what we mean is they don't cause suffering to the individual. So, for example, many of the symptoms seen in the antisocial personality disorder, which was once upon a time called sociopathy, the sociopath. A sociopath's symptoms are largely not ego dystonic to that individual, but ego syntonic. The inability to really love somebody, being amoral, not immoral, but amoral, not having a moral code that they live by. Sociopaths often lack the experience of guilt. They can do bad things and not feel bad about them. They often lack anxiety. when you might do something or think that you want to do something, and that thought or behavior would make you very upset and anxious. They don't get anxious, right? So sociopaths often have symptoms that are more ego-syntonic than ego-dystonic. Now, another example would be, let's go back to schizophrenia. Imagine hearing the voice of God. You're hallucinating the voice of God, and God is saying reassuring things to you, giving you good advice, telling you all will be well. It's still a symptom, but it is not a dystonic symptom in this example. It is a syntonic symptom, right? And so one of the things to remember is that pain hurts. Dystonic symptoms are painful. And even though that's lousy, can pain sometimes be a motivator? Can it motivate us to struggle to get from a bad place to a better place? When symptoms are ego-syntonic and comfortable to the person, actually that person is less likely to engage in treatment and to stay in treatment because they don't have the hook, right? The pain is not present. So while we don't want to seek out pain, the truth of the matter is that sometimes ego-dystonic painful symptoms are more likely to lead to somebody to seek out therapy and to work and engage in the process of getting to a less painful place. Okay. So let's go back to the DSM, and then we're going to forge ahead right now. The DSM-5 is the mental health diagnostic system that is currently in use in the United States. Now, in Europe and many other parts of the world, there are different diagnostic systems that are in use. The World Health Organization in Europe has its own set of diagnoses that they use, and there's a lot of overlap, but there also are some differences. But the DSM-5 is basically made up of hundreds of different psych disorders, each described one at a time, not only in terms of the symptoms of that disorder, but also the demographics of that disorder. So just like some physical illnesses are very common and other physical illnesses are rare, the same is true in the mental health field. There are certain diagnoses that in the United States are very common ones. There are other disorders that are much less common. Depression, of which there are different types, but diagnoses of different types of depression are very common in the United States because depression is a common psychological disorder. On the other hand, DID, dissociative identity disorder, which was once upon a time called multiple personality disorder, that's a much less common diagnosis. It exists, but it is significantly less common in frequency. So that's a piece of the demographics of it. Another example of demographics would be the ratio of a given disorder in terms of males to females. Some psychological disorders are equally common in men and women, while others are more common in one gender than in the other gender. Sociopathy, antisocial personality disorder, is significantly more common in men than women. And it's interesting to think about the etiology of that. Why might that be? Might it have to do with biology and hormones? Some people argue yes, although there's a stronger argument that it has to do with how we raise boys and girls differently, and boys get away with certain sorts of behaviors, more antisocial behaviors growing up than girls do. There are other disorders, however, that are more common in women, diagnosed in women than in men. The borderline personality disorder is more likely to be diagnosed in women than in men. Depression is another example. And again, you can always ask the question, is this a biological reason that it's more common, or might it have to do with psychology and culture, how we're raised? Probably has to do more with that. The other interesting thing about demographics is the age of onset. Some psychological disorders are very clearly present in very, very early childhood, in sometimes in very, very young kids, while other disorders might not appear until later in life. An example of that is schizophrenia. Um, Schizophrenia, which is strongly genetic and neurological, but not completely. Often the symptoms of schizophrenia, if they're going to appear, do not appear until late adolescence, and sometimes not until somebody's in their 20s or their 30s. It is relatively unusual that if somebody is 40 or older and they've never had symptoms of schizophrenia, it is relatively unusual for that to appear at that point in time. There are other types of disorders that demographically are tied to particular life events. So there's a type of depression called postpartum depression, postpartum meaning after giving birth, where you couldn't be diagnosed with it. A woman could not be diagnosed with postpartum depression until she's become a new mom, and then the symptoms might develop. So demographics are really interesting in terms of the frequency, the gender biases in disorder, the age at which they appear. And also, that's true with treatment. Some psychological disorders are far more treatable than other disorders. And again, I would ask you, does that sound like physical illness? Are some physical diseases more readily treated or cured than others? So we got a similar model. So what I want to talk about now is how mental health professionals and clinical and counseling psychologists and psychiatric social workers and psych nurses are trained to make a diagnosis. One of the things that we learn as we go through the graduate level training and then we go out in the real world and work under supervision is something that is called the medical model of diagnosis. And notice that it's called the medical model because it is very, very similar to the way that medical doctors are trained to make a diagnosis of a physical illness or a physical disease. So let me start by saying that not all mental health professionals in the United States use the model that I'm about to describe. There's a significant minority of mental health professionals that feel that the dangers and downside of making a mental health diagnosis outweigh the advantages of making a diagnosis. And while that is not my personal point of view, I have respect for where they're coming from. Let's remember this. Making a mental health diagnosis, even when it's done for beneficial, helpful reasons, is still labeling a real, live, complicated human being. Would you all agree that you have been labeled as you've gone through life? Have there been moments when somebody didn't see who you as an individual really were because they saw you through the label that they were attaching to you, right? And labels can be damaging. Now, in multicultural psych, which is a separate course, we talk a lot about the dangers of labels, right? We label people based on gender, race, religion, economic class, age, right? And those labels are dangerous because those labels reduce a complicated, real life, living, breathing you or me to a stereotype. There are dangers in diagnostic labeling, so I recognize those dangers. I personally believe that we can be aware of those dangers and thus work hard as therapists not to fall into those traps, and that appropriate diagnostic labeling can sometimes help us more deeply understand what a specific individual is struggling with. But we have to be very, very careful and very cautious in this process. And so there are mental health professionals who believe, and I have respect for this point of view again, that the downside and dangers outweigh the upside. Okay. Now, one of the realities that we're faced with in the United States is seeing a therapist, especially seeing a therapist privately, is not an inexpensive proposition. It costs money. And while some people can afford to pay out of pocket, and while it is also true that some therapists will do what's called a sliding scale, they'll reduce their fee for people who can't afford mental health services. The truth is that a lot of people rely on their medical insurance, their health coverage, to help defray the cost or some of the cost of seeing a therapist. The medical model of diagnosis, meaning making a diagnosis using the DSM-5, is required legally for insurance reimbursement. Simply put, no diagnosis, insurance companies will pay naught, right? And one of the goals of an insurance company is to pay as little as possible. So I'm going to give you a whole lot of reasons why we make a diagnosis separate from the money. But let's be real too. That's a part of our story. Without a diagnostic label from a licensed mental health professional, insurance companies will not help defray the cost of treatment. But separate from that, let me take you through the medical model of diagnosis, and we're going to do it step by step. And, here's the thing. When I talk about this in a lecture or in a class, on a whiteboard, and I write the steps down, or if I was sophisticated enough to use PowerPoint, which I'm now realizing I'm going to have to finally learn, it all looks nice and neat and tidy. In real life, human behavior never is. The medical model of diagnosis, even when done properly and accurately, will never capture the full complexity of a human being. If I'm a therapist and you're my client, and we're just starting out, there's other things about you that I need to understand to be of service to you, way above and beyond whether you have a diagnosis using the DSM. I need to know you. I need to know your story. I need to know your history. I need to know your worldview. I need to know whether you've got good support systems, whether you have people in your life who you trust, who love you, or whether you're going through life isolated and alone. I need to have some sense of your intellectual potential because smarter people can benefit from certain types of therapies as compared to people who might not be as intelligent. I need to know about where you're at with drugs and substances. All of those things can be separate from making a diagnosis, and they're more important. I need to know how your unique worldview shapes your day-to-day experiences. So please understand that making a diagnosis is a tiny little part, and sometimes not at all the most important part of the picture of you. To give that an example, imagine two people both today meet the DSM diagnostic criteria for some type of substance abuse disorder. Let's say alcohol, right? They both have legitimate difficulties managing the drug called alcohol. So they both have the same diagnostic label. But would you agree with me that underneath that similarity, they are two very different people, right? They have different sets of strengths. They have different levels of support from the world around them. Two people start with the same diagnosis. 10 years from now, one's in recovery and the other one's dead. They had the same diagnostic label, but it wasn't that determined their outcome. It was all of the other pieces of their life. So you see this cautionary tale I keep putting in about the dangers of diagnosis. But I do believe using this system properly can also have tremendous benefits. So the medical model of diagnosis is a step-by-step model, but it can sometimes be very confusing. So let's start right at the beginning. Let's imagine you're a therapist and you're meeting with a client for the first time. You know nothing about them other than a brief phone call you had when you scheduled the appointment. And you might have asked them in that brief phone call just to kind of quickly give you a sense of why they were calling, but you don't really know anything about them. If any of you have been to therapists, you know that the first couple of visits, and sometimes for much longer than that, therapists in a variety of ways have all kinds of questions about you that they want to get answered. And the reason is you cannot do therapy with somebody you don't know, right? You can't do therapy with a stranger. It's not about that. Right? And so, separate from making a diagnosis or considering whether there's a disorder that fits your situation, therapists are going to take what's called a psychosocial history. Would you agree that in some very real ways, who you are today has a lot to do with your personal background, your story, your history, your childhood, your genetics, the way you were treated by the key players in your life as you've gone through the journey that's brought you up to where you are now, the lifestyle that you've built for yourself, right? Whether you have good friends or don't, the way your mother and your father interact with you, the kind of teenage years that you've had, where you went to school, what your interests are, your loves and your hates, right? We all have a backstory. That backstory is part of the story of why we are where we are currently. Mental health professionals need to know lots of salient pieces of your backstory to be able not to make a diagnosis, but to understand you. And then another thing that's really important is to a therapist is, why are you in my office right here, right now? What happened in your life in the past recent time, maybe the past few months, that you've said to yourself, I can't go on like this, and actually found the courage or the motivation to pick up the phone and actually schedule an appointment? And that's sometimes called the why now question. In other words, if you've been struggling with issues for a period of time, what's happened recently? Why now? What triggering events may have come along in your life very recently that motivated you or somebody else to suggest to you that you need to talk to a therapist, right? So there's the longer range history going all the way back to the beginnings of you, right? And then there's the more recent stressors in your life, the more recent events in your life. So for example, let's use COVID as an example. If before the COVID epidemic happened, you were very anxious for other reasons, you were feeling anxious, and anxiety is ego dystonic, it's uncomfortable, right? Could the stresses in the past 2 months in your life, the anxiety over COVID, the isolation that a lot of us are feeling over COVID, could the events in the past couple of months have essentially pulled the trigger? Your gun was loaded from months or years, feeling anxious or feeling despair. And then these additional stresses that we're all facing, could that have, in a sense, tipped you to the point where you said, I can't go on like this, right? Another example that, I've been volunteering on a mental health crisis line the past month, and an example that I've been getting a number of calls on has been, if you've been in a relationship that has been a stressful and unhappy one, right, an ongoing relationship, pre-COVID, were there ways to escape from that relationship, right? You'd go to work, your partner would go to work, and so on. But now, might you find yourself kind of hunkered down for 7 into 8 weeks on a daily basis with the other person in your life? And could that change have bumped the dysfunctional, painful stress level of that relationship up much higher? And so now a person's in crisis, right? In a way that they weren't in crisis 2 months ago. Could we see the same thing? The rates of domestic violence are increasing. Now, that's kind of tricky because if you're in an abusive situation and you're kind of stuck at home 7 days a week with the person you experience as your abuser, actually, could that make it harder to get treatment right now? So, life is complicated. But separate from making a diagnosis, there's a whole lot of things we want to know. And part of it is, what's the backstory of you? But also, are you in crisis in your life currently? Have certain recent events, in a sense, moved you from a longer term problem into some sort of acute crisis level problem, right? Now, could you be doing very, very well in life and not be carrying a lot of baggage from childhood or adolescence, right? And still move into crisis? Of course, right? Sometimes the reason people pick up the phone to see a therapist and schedule an appointment is they were doing fine and then they got blindsided by something in their life. And it's overwhelmingly stressful, right? Could that happen to any one of us? The answer is yes. Right? And there's some disorders that describe that, like post-traumatic stress disorder. Right? No matter how healthy you are psychologically, no matter how together you feel, can bad things happen to good people? And at least for a while, could those very stressful, crisis-oriented life events push somebody to a place where they begin to decompensate and they're not functioning as well in the world, and that motivates them to get help, right? And some people are interesting. Some people think they're so tough, they're so bulletproof, they're immune to that. Nobody's immune to that. It can happen to anybody. There were a lot of cops and firefighters in Lower Manhattan on the day before 9/11 who had been on the job for years and believed in their hearts that they had seen it all and nothing could affect them anymore. They were bulletproof. If you talk to them on 9/12, the day after 9/11, they weren't saying that anymore, right? So everybody is fragile. Are some people more fragile than others? Yes, sure. Could you be more fragile at 15 than at 25? Yes, right? But even people who kind of experience themselves as bulletproof and tough, there are certain crises which can trigger in them at least a temporary falling apart and not able to function. That's not a judgment. That's just what makes us human. So let's get back to the medical model of diagnosis. One of the things that mental health professionals are trained to do, those who use this model, is know what questions to ask to elicit from the client's statements about what is causing them concern. And secondly, good therapists are trained to know what to look for and observe in a client's behavior. So step number one in the medical model of diagnosis is to elicit from a client his or her symptoms, and at the same time to observe the client looking for certain signs. So I'm now introducing two terms, signs and symptoms, and they are not exactly the same. Irish breakfast tea with 3 shots of Irish whiskey. That's not really true, as far as you know. Okay. Symptoms are behaviors of concern to the client. So one of the things that a mental health professional wants to know is, from the client's worldview, what's wrong in your life? What are you concerned about? What hurts? So if a client says, for the past 3 months of my life, I have been feeling sadder than I ever have before, because they're reporting it, it's a symptom. If a client says, I'm having these really bad thoughts, and you explore that with them, and they basically say to you, look, I'm not going to do it, but the past couple of weeks I've been having these really scary thoughts about hurting myself. That's another symptom. If a client says, I lost my appetite 2 months ago, and I'm not trying to lose weight, but I've lost a lot of weight, and when I eat food, it tastes like cardboard. That's a symptom. So you see, part of being a good therapist is to ask the right questions in the right way to elicit, to make it safe for the client to share their symptoms. Now, that might sound easy, but it's not always easy. Could you have things bothering you or symptoms that you don't want to talk about? You don't even want to think about, all right? Have you ever noticed when you take something that's kind of buzzing around in your head and you say it aloud to another human being, that makes it kind of real in a different sort of way? And could that be something you don't feel ready to do? So it's not like a client is going to come in having, with a list of their symptoms and feeling safe to talk about them. It doesn't work that way. And good therapists have an ability to almost read between the lines and to be gentle, right? You might not be willing to discuss certain sorts of your world experience with me or with a therapist for a period of time. So, again, when you talk about it on like writing it on a whiteboard, it sounds kind of simple, but it is far from simple. Um, One of the symptoms I just gave you was suicidal ideation, thoughts of suicide. Could that be a terrifying thing to talk about for a lot of reasons, right? Um, a person might not want to talk about the depth of that experience because they're afraid they're going to be committed or hospitalized and they don't want that to happen, right? Or simply admitting to it is something that they're not ready to do. So it takes a lot of skill and training on the part of a therapist to be good at knowing what to ask and how to read between those lines to elicit what the client's symptoms are. But in addition to symptoms, we're also trained to look for signs. Now, symptoms are behaviors reported by the client. Signs are behaviors of significance observed by the therapist. So a client doesn't report signs. Signs are things that well-trained therapists notice that help reveal what's going on diagnostically inside that client. Now, some of these are obvious, right? Um, if you and I meet in my waiting room for the first time and we're walking down the hall to my office, and you haven't even been in my office yet, if you're walking very, very slowly, slouched over, hunkered down like you're exhausted, that's a sign. Now, could it be a sign of several different things? Yeah. Could it be a sign of a physical sign of depression? Yes. Could it be that an hour before the visit, you were so anxious, you took a big dose of Xanax or Klonopin, and that's why you're walking like that, right? Right? Could you have Parkinson's disease, which makes you walk like that? So you see, I'm going to notice it, and it's a sign. But without more data, I don't know what it's a sign of. I need to get more data, right? Or let's take the opposite. You rush down the hall. I'm walking at a normal pace, and you zoom down the hall at 50 miles an hour, almost semi-running to get to my office. Could that be a sign not of depression, but of mania, the opposite of depression, which is something we might see in the bipolar disorder? But could it also be that you took a big loading dose of Adderall or amphetamines an hour before, right? Or could it simply be straight up anxiety, right? So again, it's a sign, but I'm not sure what it's a sign of at that moment. I have to figure that out. If you come into my office and you walk in wearing mirrored sunglasses, and we meet for an hour and a half the first visit, and you never take those mirrored sunglasses off, could that be a sign? Right? Could it be a sign that you don't want me to see your eyes? Could it be a sign that you don't want me to see your eyes because I'm trained to look at your eyes and your pupil size and maybe scope out what drugs you do? Or could you be incredibly paranoid? Could you feel exposed and vulnerable, like somebody's reading your mind when they can see your eyes, right? again. Or could you just have sensitive eyes? It's a sign, but I don't know what it's a sign of. Let me give you one more example. I'll use me as the client. You're the therapist, I'm the client. We're sitting face to face. You're interviewing me for the first time. And most of the time, I'm making eye contact with you and I'm answering your questions. But every once in a while, I kind of look up to that part of the room and I stare, kind of perplexed. And then I come back again. And then 10 minutes later, and then I come back again. What might be going on? See, if this was a real face-to-face class, some of you might actually answer. Could that be a sign of an auditory or a visual hallucination that you're having? You're hearing a voice or seeing something up there in that corner of the room, and it's very real to you, and so it draws your attention away. I don't know, but I know it means something, and I've got to figure out what it is. So step one is to discover from a client her signs and her symptoms. I remember once on an exam, a student, clearly not knowing what signs were, he wrote, yeah, like, what's your astrological sign? Because like if you're a Libra, you're more likely to have these disorders than if you're a Capricorn. Very creative answer. Completely wrong, but I respected the creativity involved. Okay, now, could it take weeks to identify a client's signs and symptoms? Right? Imagine a teenage kid that's been forced into therapy by his or her parents. Could they be so pissed off that they don't give you much to work with? Like you're trying to talk to them about what, and they give you nothing, right? They sit there kind of mute with a pissed off look on their face, right? So in real life, it's not like, even if you're a great therapist, it's not like after one visit, you got this stuff figured out. This is a journey. This is a process. Now, before we get to step two, let me mention some things that therapists do sometimes, that psychologists do sometimes when we are not having a clear understanding. Just as psychiatrists are trained to prescribe meds, psychologists don't prescribe meds. Here's the flip. Psychologists are trained to administer and interpret psychological tests. Psychiatrists don't do that. Now, there are hundreds of different psychological tests out there, and some measure intelligence, and some measure personality traits, and some measure aptitudes. Like if you're going to a career counselor, what are your aptitudes? But the tests that I'm talking about are tests that are more designed to help a mental health professional make a diagnosis, or to help a mental health professional understand how one individual's personality works. We have many of these tests. Some of these tests are called projective tests. The famous one that's still used, but not as much, is the Rorschach test, also known as the Inkblot test. Another one is called the TAT, where we show people pictures and we ask them to make up stories. One that we still use a lot is called figure drawings: draw a house, draw a tree, draw a person. And then there are other types of personality diagnostic tests like the MMPI that's frequently used, depression inventory scales, anxiety inventory scales, psychosis scales. A lot of times, psychologists don't need to use these tests because sometimes we get the data that we need to make a diagnosis, but sometimes we don't. So there are occasions when psychologists specifically will administer certain types of psychological test batteries as a way to A, better understand that client, and B, to help us make the correct diagnosis. Just want to mention that to you. And if any of you were psych majors and stay that journey, foolish. No, it's a great journey. You will take somewhere on that journey a course in what's called tests and measurements, where you learn about these tests. And you may take another course called the projective testing, where you learn how to administer and interpret like the Rorschach test and the TAT and so on. Okay, so step number one, signs and symptoms. That's going to take us to step number two. We then look for whether those signs and symptoms for that individual fit well enough. It's called good enough fit. A particular psychological disorder in the DSM-5. Remember the DSM-5? Hundreds of different psych disorders, each characterized by signs and symptoms. We ask ourselves the question, is there a good enough fit between this individual's signs and symptoms and a recognized disorder in the DSM-5? Now, that does not mean that that client has to have every single sign and symptom to make the diagnosis, but they have to have enough of them. And it varies from disorder to disorder. So in some disorders, you might see a qualifier, which would basically say, to diagnose somebody with this disorder, they need to have had 6 out of the following 10 symptoms present in their behavior for a minimum of the past 6 months. If they only have 4 out of 10, and those symptoms have only been there for 3 months, then legally, legitimately, you cannot make the diagnosis. And this is important. For the diagnostic system to be useful, we don't want to underdiagnose people who really have disorders, but we sure as hell don't want to overdiagnose people who have these disorders, right? We don't want false positives or false negatives, right? And since diagnosing people is a powerful and potentially bad thing to do if we screw it up, we sure don't want to overdiagnose. And that's why there are these specific criteria for different disorders. There are disorders where the symptoms have to have been present for a minimum of 2 years to make the diagnosis. The dysthymic disorder, which is a particular type of depression, requires symptoms present most days, certain symptoms of depression, for a minimum of 2 years. Okay, so we look for whether the signs and symptoms of this given individual have a good enough fit. This is step 2, with a recognized disorder in the DSM-5. If there is a good enough fit, then we move to step 3. Step 3 is to actually make the diagnosis, to name the particular disorder. Dysthymic disorder, schizophrenia paranoid type, ADHD, OCD, whatever it is. And remember, there are hundreds. That's step number 3. And we only do that if it's legit. And then that takes us finally to step number 4. Step number 3, diagnosis, is abbreviated DX. Step number 4, treatment, is abbreviated TX. So if we've got the correct DX, step number 3, now we can begin to think about the appropriate possibilities in terms of TX, treatments, aka therapy, right? One of the most important reasons to get the diagnosis right is so we can think intelligently about the kinds of treatments that can help this individual. Now, would you agree this sounds very much like medicine? It is, right? You wake up tomorrow morning, let's forget COVID. You wake up tomorrow morning, your throat is sore, your lymph nodes are swollen, and you have a fever. You open your mouth, shine a flashlight in, look in the mirror, and you see little white patches on the back of your throat. Are those symptoms? Right? You bring your symptoms to your family doc. She examines you, she runs a couple of tests, and she diagnoses you, number 3, with a strep throat infection. Since it's a strep throat infection, are there certain treatments, step 4, which are appropriate, like certain antibiotics? But let's say your diagnosis is different, and you're diagnosed with a viral and throat infection. Now we're at step 4. Should she prescribe antibiotics to you? Nope, she shouldn't, because antibiotics only work on bacterial infections. They don't work on viral infections, right? Different diagnosis, different treatment. To some extent, we have the same issue in the mental health field. By making a different by getting the diagnosis right, we can think about the correct treatments which are more likely to help that individual. Okay, let me go back to something. Let me pose it as a question. Is it possible that a client could have more than one DSM-5 diagnosis at the same time? While you think about that, let me drink my tea. I got up at 5:30 this morning. That has not happened for 10 years. I don't know about you guys, but my sleep-wake schedule, living in this weird world, is completely different than it was. It's easy to get up at 5:30 because I can always rationalize it and kind of go back to bed and get more sleep whenever I want. Being stuck at home most of the time. Anyway, right? The answer to my question is, you bet. Yes. Not always true, right? But if you think about it, are there situations where one psychological disorder left untreated can morph into other disorders kind of layered on top of it? So let me give you a couple of examples. Imagine somebody who has been living with untreated PTSD, post-traumatic stress disorder, for the last 5 years. An individual who experienced a series of horribly upsetting tragic events 5-6 years ago. Time has passed, and those traumatic events are no longer happening in real life, but psychologically, they continue to flash back and re-experience those traumas from years ago, right? And somebody's been living like that with these symptoms on a daily basis. So they're having flashbacks. Even when they're calm, they're not calm anymore. They can't sleep at night. There's places that they won't go to anymore because when they drive down that road or go to that movie, they see or hear or re-experience certain things which have them re-experience the trauma. And they've been living like that without getting better for a period of years. That's the original problem. Could you see how certain other problems could spin off of that one if time goes on? If you're living with PTSD untreated and the symptoms are deeply ego dystonic, might you develop a depression on top of your PTSD? Simply put, it's a depressing way to live, experiencing flashbacks on pretty much a daily basis. Let me add one more layer that's possible. So if you have the trauma that you're re-experiencing and now you're feeling despair, might you start to self-medicate and get into trouble with a particular drug as a way to self-medicate away your pain and your despair? And while it could be any drug, potentially, in America, as you probably know, the most common of them all is alcohol because it's the easy one to access. Like when we went into shutdown here, we kept the liquor stores open, right? So could an individual, in my scenario, actually have 3 different diagnoses? Originally PTSD, which is still there, some sort of depression, and now some sort of substance abuse on top. And would it be important for a therapist to recognize that there is in that situation a polydiagnosis, a dual diagnosis? There's more than one problem going on. And it creates a lot of challenging situations. Might you have to, in a sense, do triage? Might you have to think about, for this person to get to a better place, which parts of these problems might need to be addressed first before other pieces of the puzzle can be addressed? Simply put, it's very difficult to do effective therapy when somebody shows up at your office drunk. Might you have to help that client work on some of the substance abuse problems, at least initially, to create more of a space for other sorts of therapies to benefit? Or in a different scenario, might a client need medication treatments to deal with some of their symptoms before other sorts of talking therapies are going to be very productive? And that could be true, let's say, in schizophrenia, where a person with schizophrenia who's hallucinating and delusional, i.e. psychotic, out of touch with reality, it's very difficult to do effective therapy with somebody who's hearing the devil talk to them, because the devil's voice is more important, frankly, than your voice as a therapist. So sometimes we have what's called multiple diagnoses. But now let me give you the opposite scenario. Could you go to a therapist because you're not happy? Could this medical model be done? And could you wind up with no diagnosis at all? You could be an unhappy, miserable person. That doesn't mean you have a mental disorder, right? But could therapy actually still be beneficial? You don't have to have a diagnostic disorder to benefit from therapy, right? There are times you and I, certainly I, get into therapy as a function of feeling stuck, feeling blocked, feeling confused about where I want to go in life. And there's no DSM diagnostic code for that. So again, life is complicated. People often joke about therapists being in therapy. Let me put it another way. I would never go to a therapist who has not himself or herself been in therapy, at least at times, ever. Good therapists are frequently in and out of therapy because they recognize they need to work on their own issues for their own happiness, but also to keep their own stuff out of the way of working with their clients, right? Can a therapist's own struggles, if not being addressed by the therapist, sometimes lead to incompetent help for clients, right? So the joke, why would a therapist need a therapist? There's a very valid answer to that. I think there's another reason. I think the best therapists are people who know the turf. And they don't just know it because they're smart and they went to graduate school and they got good training. They know it because they're living, breathing, struggling human beings like everybody else. You probably are aware that some of the best addiction counselors are people who are in long-term recovery from their own addictions. Is that a group that has great empathy for a group of people who often other folks have no empathy for? Yep. There's also a second reason. Do you know the cons? Do you know how denial works? Do you know the maneuvers when you've been there, done that yourself? So, just kind of as an aside, I think that's an important part of the equation. Okay, so all of this is being done in aid of coming up with step number 4, a good treatment plan, right? How are we going to help this person? Okay, we're at 53 minutes, and I'm going to end here. I have a little bit more to do, and that's going to come at you tomorrow. So I'm going to shut this down in just a minute. I'm going to upload it, and I will be sending to you today a short exam 3, and I promise you it's not going to be a killer. It's going to be a very limited exam. It's just focusing on the material since exam 2 ended. It's going to be several short answer questions, short answer essays, not long essays like exam 2. So I want to make that very user-friendly, but I need to do another maybe 30-minute video tomorrow to finish this section up, and we're going to call it a semester. So if you need to talk to me or Lyndon at sussex.edu, please reach out to me. When you watch this video, would you make a comment on YouTube letting me know you watched it? And any comments or questions you might have, put them up as well. So I am going to now upload this. The uploads have been taking hours. I think there's probably a lot of faculty using YouTube right now. Okay, but Lyndon at sussex.edu, anything I can do for you? What else? I emailed your grades yesterday, or maybe the day before, but I think yesterday. So, again, you got 2-letter grades, one for each essay that you did, and the grades were pretty good. Okay, Talk to you soon.